In an ideal body alignment, the segments are found in a centrated position, and the muscles that ensure this position are in balance. To be able to assess the ideal position of individual segments, it is necessary to know the anatomical situation and its relationship to loading during normal movement activities. In an ideal situation, all three axes, shown here in blue, are parallel to each other. The pelvic floor axis is a line connecting the symphysis and the end of the coccyx. The diaphragm axis connects the tip of the sternum and the 10th thoracic vertebrae. The cranial axis determines the alignment of the cervical spine and intersects the floor of the mouth. Thanks to modern assessment methods, we can describe anatomical alignment very well. The presentation and the assessment of local and global parameters are linked to posture and allow for better assessment of biomechanical interconnections. Local parameters in the pelvic area include, for example, pelvic tilt, sacral slope, pelvic incidence angle, lumbosacral angle, or slip angle. In terms of overall posture, we assess the so-called global parameters because deviations in spinal curvatures lead to consequences involving the entire spine. The sagittal contour of the spine as a whole is assessed using the plumb line. The kyphotic and lordotic spinal curvatures in the sagittal plane can be assessed using Cobb angles. When assessing breathing, the angle that we often notice is the angle between the clavicle and the horizontal. In ideal alignment, this angle is 10 to 15 degrees. When the breathing pattern is not ideal and the rib cage is moving craniocaudally, this angle decreases and the clavicles become more horizontal. The angle between the scapula and the clavicle is 60 degrees. This angle, to a certain degree, determines the position of the scapula on the thorax. The mentioned anatomical findings do not have clinical relevance if they are not associated with a functional assessment. The diaphragm, as the main respiratory muscle, is part of a functional unit ensuring postural stabilization. During inspiration, it flattens and the centrum tendinum descends caudally. Assuming co-activation of other muscles, it can brace itself against the internal organs and contribute to an increase in intra-abdominal pressure. Due to this activity and costovertebral joint rotation, the lower ribs move laterally and the intercostal spaces widen. With upper rib rotation during inspiration, we can also observe ribcage widening in an anterior to posterior direction and a ventral movement of the sternum. The foundation of ideal postural stabilization is the flattening of the diaphragm and the coordinated activity of the following muscles. The muscles in the back part of the trunk work in coordination with the frontal part. The spinal extensors work eccentrically during inspiration. We can observe their expansion. In their postural function, the diaphragm and the pelvic floor also assist with trunk stabilization. The diaphragm can flatten and brace itself against the internal organs given the eccentric activity of the abdominal muscles and the pelvic floor muscles. It is important for the muscles to create an adequate and balanced tension. The diaphragm and the pelvic floor have similar anatomical structure, and in addition to their respiratory and postural functions, they also fulfill a sphincter function. The abdominal muscles are organized in several layers that altogether form one functional unit. The insertion of the rectus abdominis to the lower part of the sternum and to the adjacent part of the trunk assists with the anterior expansion of the rib cage during inspiration. Transverse abdominis and the internal obliques together with other muscles, play an irreplaceable part in the expansion of the lower aperture of the rib cage and assist this way with correct function of the diaphragm. The distribution of the intra-abdominal pressure is ideally spread in all directions. During assessment, we check the pressure distribution above the groins as well as the dorsolateral expansion at the lumbar triangle. In these regions, the expansion of intra-abdominal pressure is usually the weakest. Thanks to their insertion, the external obliques stabilize the lower ribs and assist in the widening of intercostal spaces in the lower part of the rib cage and later the upper part of the rib cage. Postural stabilization is a prerequisite for every movement activity. Within the postural system, diaphragm activation plays an important role in the creation of intra-abdominal pressure, which can be increased based on the amount of loading. Intra-abdominal pressure can be viewed as the blue mechanical model on the right. In the first scenario, when the diaphragm breathes freely from one yellow line to the other, an ideal interplay of all muscles allows for maintaining relatively constant intra-abdominal pressure, which we need, for example, in standing. When the demand on spinal stabilization increases, for example when lifting a heavy object, the diaphragm flattens fully, all the way to the green line, to increase the intra-abdominal pressure to a maximum level. In such situations, it is possible to turn off the respiratory function for a few seconds and use the postural function to its full potential. Without a doubt, the most difficult coordination occurs during the interconnection of these two functions of the diaphragm during full loading. This means that the diaphragm, by its flattening, has to develop maximum pressure while at the same time breathing, also differently moving in its descended position. The same can be seen in transection. At the time of diaphragm flattening, the abdominal wall works eccentrically in the same fashion as the pelvic floor and the spinal extensors. This tension in all directions activates all muscles and contributes in this way, increasing the intra-abdominal pressure and spinal stabilization. However, the timing of the activation is important. The concentric activity of the abdominal muscles cannot precede the flattening of the diaphragm. The intra-abdominal pressure can automatically be increased on the demands of loading. It should be increased so that the segments maintain its neutral position and are protected from overloading. Mobility of internal organs and the surrounding tissues is important for an ideal function of all muscles involved in postural stabilization. The tissues can lose their mobility during inflammation when post-surgical scars are present or other pathological processes occur within the abdominal cavity. This fact needs to be taken into consideration during therapy when the postural stabilization functions are insufficient. As it was explained before, the diaphragm has, in addition to its respiratory function, also a fundamental postural function that assures a centrated position of individual spinal segments. When the demands for stabilization increase, the diaphragm automatically flattens regardless of its respiratory function. When decentration of the pelvis and the trunk occurs, pathological movement patterns occur as well as imbalance in abdominal muscles. Even within one single muscle, inconsistent muscle tension can be seen. For explanation and during therapy, the function of the abdominal wall can be compared to the function of a belt that hardens the trunk and maintains the spinal segments in a centrated position thanks to the balanced activity of all parts of the abdominal muscles. If the diaphragm contracts physiologically and an ideal stabilization of the tendons occur, the centrum tendinum descends and the insertion in the lumbar spine can slightly distract the lumbar spinal segments. In the picture, we can see an ideal distribution of the intra-abdominal pressure that forms the spinal support and an adequate inclusion of individual parts of muscles during movement, which we call ideal timing. Since the movement is never an isolated function of only one muscle, we speak of coordination between all individual muscles within the entire postural complex. During inspiration, serratus posterior inferior also assists in expanding and unweighing the lumbar spine. When comparing physiology with pathology, we notice which changes occur in the function of the diaphragm and their effects on the entire postural control of the trunk. With incorrect function of the diaphragm and other muscles, the rib cage moves in a craniocaudal direction. The shoulders elevate, the spine becomes unstable in the sagittal plane during movement, and the clavicles become more horizontal. The diaphragm, after fulfilling its respiratory and postural functions, requires coordinated activity of other muscles. The abdominal muscles, especially the external obliques, can ensure stabilization of lower ribs and assist in creating the so-called punctum fixum, or a stable point that the diaphragm uses to flatten and brace itself against the internal organs. If this coactivity is not functioning properly and the external obliques do not stabilize the ribs, we can observe higher activity in the posterior or lumbar part of the diaphragm. The diaphragm pulls itself toward its insertion at the lumbar spine due to the insufficient stabilization at the sternal and costal insertions. Centrum tendinum is pulled in a posterior direction. The intercostal spaces become narrower and the costovertebral joints become less mobile. During assessment, we can see the lack of laterodorsal expansion between the lower ribs and the iliac crest. In these areas, we can observe skin creases that often suggest which areas are the most insufficient. From the front, we can also palpate in the groin region more laterally, as this is the area often seen without insufficient distribution of intra-abdominal pressure. The following is observed in what we call an hourglass syndrome. With insufficient spinal stabilization, the diaphragm does not flatten sufficiently. The lower aperture of the rib cage does not expand, and the content of the abdominal cavity is not sufficiently compressed. This leads to an increased activity of the superficial spinal extensors. The insufficient contraction of the diaphragm can be caused by a more slanted positioning of the axis of the diaphragm in the sagittal plane. Trunk stiffness, especially in the lower segment, or imbalanced activity of the stabilizing muscles. Dysfunction of the diaphragm can also be caused by impaired muscular timing when concentric activity of the upper part of the rectus abdominis and external obliques precede the activity of the diaphragm. Insufficient activity is in the internal obliques, lower segment of the rectus abdominis and transverse abdominis. In a pathological movement pattern, the resulting presentation is inefficient and requires much more energy expenditure. The result is then a less than ideal centralization or incorrect loading of individual segments, microtrauma to a tendon or a bone, which often leads to an altered movement pattern, an injury, or a nerve root irritation. In an ideal body posture, the segments are in a centrated position. If the trunk and pelvis move forward or backward outside of the ideal alignment in a sagittal plane, other segments get influenced as well as the overall body posture. Here are the 4 most common examples. With an anterior pelvic tilt and a cranial shift of the trunk with the lower ribs protruding, the axis of the diaphragm and the pelvis become slanted in a similar fashion as scissors opening. With segment decentration, muscle imbalance and changing muscle tone occurs. During incorrect stabilization, the upper part of the rectus abdominis and the external obliques become overactive. On the other hand, transversus abdominis, internal obliques, and the lower part of the rectus abdominis are not sufficiently activated. We can observe overactive spinal extensors and changes in the breathing pattern. The postural system functions as one unit. The alignment of the axial organ influences the alignment of the extremities and vice versa. In the second example, in addition to the cranial shift of the trunk, we can also observe its shift forward in front of the body axis. The anterior pelvic tilt persists. This posture typically increases the tension in the entire posterior part of the body and lower extremities. In the third scenario, we observe posterior pelvic tilt and a backward shift of the rib cage. The axis of the pelvis and the rib cage open dorsally, and body weight shifts posteriorly. Increased thoracic kyphosis is often the compensatory strategy in such postures. In another pathological scenario, the trunk is positioned behind the pelvis. In this scenario, the pelvis stays in a slight anterior tilt and the trunk is shifted posteriorly in relation to the pelvis. As a result of postural muscle imbalance and a sense of hypotonia, we can observe flaccid body posture. This is demonstrated by the head being shifted forward, a kyphotic trunk, and a protruded lower part of the abdomen. Imbalanced muscle tone is observed in every type of decentrated body posture. In patients with pathological body postures, certain spinal segments are often overloaded and become hypermobile and compensate for segments that are, on the contrary, restricted in movement. When assessing correct body posture, it is ideal to first focus on the centrated alignment of the segments, followed by balanced muscle activity.
Functional assessment, according to the dynamic neuromuscular stabilization concept, compares individual postural locomotion patterns with developmental patterns defining optimal muscle coordination. Based on the comparison, it's possible to identify any deviations from optimal muscle function and functional centration of individual segments. The essential part of the DNS assessment is evaluation of dynamic postural trunk stabilization. It's critically important to analyze muscle coordination responsible for stabilization of the entire core and the quality of the postural stabilization of the spine, chest, and pelvis. During the examination, you evaluate various parameters such as the dual roles of the diaphragm in stabilization and respiratory function, the ability to maintain individual body segments in a neutral-centered position, muscle coordination, the distribution of activation between the superficial and deep muscle structures, symmetry and timing in the activation of the stabilization muscles. You also evaluate the adequacy of muscle activity under load, assess compensatory mechanisms, and observe the spread of muscle activity to other segments of the body. In clinical practice, you use several tests. The diaphragm test. Under normal conditions, the diaphragm functions simultaneously as a respiratory, postural, and sphincter muscle. Therefore, to analyze diaphragmatic capacity, you must focus on respiratory function assessment, where you evaluate the lateral excursion of the lower ribs during deep inhalation. Postural function evaluation, where you analyze the ability to increase intra-abdominal pressure following full exhalation. And finally, the ability to combine respiratory and postural function of the diaphragm, assessing the ability to breathe normally while maintaining a slightly raised intra-abdominal pressure. The patient sits on a massage table with the spine upright. The thighs are fully supported with the lower legs hanging freely and the hands relaxed. Ask the patient to breathe normally while you monitor the quality of the breathing stereotype, observing the movement of the ribs, the chest as a whole, the shoulder blades and the spine. To further evaluate the respiratory function, palpate the lower parts of the chest bilaterally, placing your fingers along the lower intercostal spaces. When respiratory function is normal, the lower ribs move laterally and the lower intercostal spaces widen. Chest and shoulder blades should not move cranially. Spine is maintained in an upright position and should not exhibit flexion in thoracic or lumbar spine. By palpation, you evaluate the expansion of the lower rib cage, which is directly related to diaphragmatic flattening. When respiration is dysfunctional, you will see the activation of auxiliary respiratory muscles, especially sternocleidomastoid, scalenes, pectoralis and upper trapezius muscles. In this case, the activation under the therapist's fingers is minimal and the patient's clavicles and shoulders are elevated. With each inhalation, the patient's chest and shoulders move cranially, the clavicles are located horizontally, and in combination with the lack of lateral expansion of the lower part of the rib cage, this causes a pathological synkinesis of the spine. Asymmetry is often observed with the disturbance more prominent on one side. Instruct the patient to take a deep breath. With optimal function, the diaphragm descends caudally. The lower intercostal spaces widen as a result of intercostal muscle activation. The abdominal wall below the ribs expand proportionally in all directions. The next step of the diaphragm test is palpation dorsolaterally below the ribs, anatomically at the site of the trigonum lumbale. Here you palpate to examine the postural function of the diaphragm. The ability to lower and expand the diaphragm to its full extent and regulate intra-abdominal pressure. A simple command is used to instruct the patient. Please feel my fingers and push my fingers away. Evaluate the ability to symmetrically and effectively expand the abdominal wall. The diaphragm descends caudally solely due to postural function as the patient is not breathing during this test. The degree of abdominal wall excursion, the force of the expansion under the therapist's fingers, correlates with postural functional capacity of diaphragm. With optimal performance, the patient can activate the diaphragm in coordination with the activity of abdominal and pelvic floor muscles. The activation is symmetrical and effective. The lower thoracic sections expand and the intercostal spaces widen. The spine remains upright throughout the whole test. To further analyze postural function, also palpate the area above the inguinal region to assess the quality and symmetry of intra-abdominal pressure activation. For optimal trunk stabilization, you should expect eccentric activation of the coordinated abdominal wall, inclusive of external and internal oblique, transverse and rectus abdominis muscles. Use the same instructions when testing from the front. Please push my fingers away. In suboptimal performance, the activity of the upper part of the rectus abdominis dominates and causes the umbilicus to be pulled up. You may also observe asymmetry, minimal or no capacity to generate the intra-abdominal pressure in the inguinal area. In normal activity, the diaphragm must simultaneously perform respiratory and postural function. Therefore, we must assess the ability to coordinate respiratory and postural function. This means the patient should be able to breathe normally while maintaining sufficient intra-abdominal pressure. We instruct the patient, please push into my fingers while breathing. Evaluation of the intra-abdominal pressure regulation while supine. Here you examine the coordination between the diaphragm and other stabilizing muscles. We place the patient in a supine position with the legs held above the table. The legs are flexed at the hips, knees and ankles at approximately 90 degrees. The knees should be the width of the pelvis apart. First, support the patient's feet, then slowly remove the support whilst instructing the patient to please maintain your legs in this position. During this test, check if the patient is able to maintain the legs in the air while keeping the trunk stable and still. Maintaining their legs in the air should increase intra-abdominal pressure enough to evoke balanced activity between anterior and posterior trunk muscles. Under this load, the spine, chest and pelvis should remain in a neutral, relaxed position. You can also test the quality of stabilization during phasic movements of the legs. Optimal core muscle coordination and intra-abdominal pressure stabilizes the spine, which serves as a fixing point for the hip flexors attached to the spine. With ideal trunk stability, note the ability to perform isolated movement of the lower extremities without any trunk movement. The whole trunk stays stable and the movement occurs in the hip joints. This ideal pattern occurs in a healthy infant between the 3rd and 4th month of development. If postural function is impaired, the following defects can be observed. The failure of the global stabilization pattern manifests by excessive activation of the superficial paraspinal muscles, resulting in the open scissor syndrome and an increase in the patient's lumbar lordosis. Both visually and by palpation, you can identify a lack of activation of the lateral dorsal parts of the abdominal wall and the area above the inguinal region. Clinically, you will observe asymmetric or unbalanced activation of different parts of the abdominal wall, usually with the dominance of the upper part of the rectus abdominis and insufficient activity of the lower abdominal wall. The umbilicus can be pulled cephalad and turned upwards. Diastasis of the abdominal muscles in the linea alba may be visible or palpable. Poor trunk stabilization or lack of intra-abdominal pressure control fails to maintain the spine in a neutral position, and as such the patient cannot create a stable fixed point, punctum fixum, for the hip flexor muscles. The patient is unable to maintain a stable, centered posture, maintaining the legs in the testing position. At the same time, compensatory mechanisms can be observed in the cervical spine. The head is extended posterior and shoulder protraction is often associated with chest elevation. Another typical picture of compromised function is excessive lumbar kyphosis with a posterior pelvic tilt. This usually occurs as the patient tries to prevent arching of the lower back. In doing so, the patient pushes and flexes the lower back towards the table while overactivating the rectus abdominis and tipping the head backwards. Extension test. The trunk extension test can be performed with or without symmetrical arm support. This ideal pattern with symmetrical arm support occurs in a healthy infant between the 3rd and 4th month of development. When testing trunk extension without arm support, the patient lies prone, keeping the upper extremities relaxed along the body. Instruct the patient to lift the head and trunk above the mat, performing slight extension of the spine. With optimal function, the pelvis remains on the mat in a neutral position, while a smooth extension of the entire spine can be observed. The body lifts away from the mat, and the extension is performed to its full extent. A balanced activity of the ventral and dorsal trunk musculature is supported by appropriate intra-abdominal pressure regulation. All parts of the abdominal wall, including lateral dorsal parts, are activated proportionally. When observing the ideal trunk extension stereotype from above, you can observe that the lateral abdominal wall is straight on both sides, as if connecting the lower ribs with the pelvis. There is appropriate activity of the spine extensors, which can be observed and palpated. The shoulder blades remain in the neutral position, connecting to the chest, while not moving into adduction, elevation, or external rotation. If the core stabilization is insufficient, the curve of the spinal extension is not smooth and the pelvis tilts anteriorly. The trunk remains on the mat while extension occurs mainly in the cervical and lumbar spine. The paraspinal lumbar muscles are overactive. The activity of the lateral abdominal muscles is minimal, resulting in the convex bulging of the lower portion of the abdominal wall bilaterally. The area of the transversus abdominis aponeurosis becomes concave. A frequent clinical sign of abnormal extension pattern is excessive activity of the hamstring muscles. This may sometimes be associated with hyperactivity of the triceps surae. In addition, you may see insufficient coactivation between deep neck flexors and extensors, hypertonus of the upper scapular fixators, neck hyperextension and decentration of the shoulder girdle. Extension stereotype and the same parameters can be assessed with the patient standing. Check whether the spinal extension is smooth, the coordination between the anterior and posterior trunk muscles is proportional. If it is insufficient, we will see an anterior pelvic tilt, cervical and lumbar hyperextension, and a lack of segmental extension in the thoracic spine. You may also observe other compensatory mechanisms such as knee flexion. The test on all fours. The patient uses hands and knees for support. The knee distance correlates approximately with the width of the pelvis. The thighs and the arms are perpendicular to the ground. As the patient moves into position, observe the centration of the individual supporting segments and ask the patient to slowly rock the weight of the body back and forth. When observing from the side, the spinal alignment should not change during movement. The trunk should be stable and the movement occurring mainly in shoulder and hip joints. When observing from above, the shoulder blades must be in a neutral position connecting to the chest. The head is in line with the spine, the pelvis is in a neutral position, the spine is straight, and the activity of all trunk muscles should be well balanced. You should also check for centration and muscle coordination of arms and legs. Ideally, you will observe proportional support on both hands. The signs of insufficient core stabilization include spinal collapse in the sagittal plane. While moving back and forth, the patient does not maintain neutral and upright posture of the spine. Often, you may observe lumbar hypolordosis associated with an anterior pelvic tilt, as well as increased cervical lordosis associated with a posterior head tilt. Another manifestation of abnormal stereotype is increased lumbar lordosis with thoracic hyperkyphosis. This is often associated with neck flexion and an anterior head position. The patient cannot maintain an upright spine with the head in line with the spine. As the body moves backwards, you can often see an increase in spine kyphosis. The patient is unable to maintain the spine in neutral posture when moving back and forth. It is also important to check scapular position. If poorly stabilized, the shoulder blades move in all different directions instead of being connected to the chest in a neutral position during the trunk movement. One example of poor posture is excessive thoracic lordosis, reversal of the curve, accompanied by scapular adduction and elevation. At the same time, you will observe decentrated position of the upper extremity joints, with shoulders in protraction and internal rotation, the elbow joints in hyperextension, and the hand support is dominantly on the ulnar aspect. Another abnormal stereotype presents with increased thoracic kyphosis along with the scapular abduction and external rotation of the lower scapular angles. This stereotype is coupled with decentration of the peripheral arm joints, usually exhibiting elbow flexion. This poor stereotype and segmental decentration can also be seen in the lower extremities. Anterior-pelvic tilt is often associated with internal rotation of the hip joints, resulting in overloading of the lateral parts of the knees and pronounced adduction. Increased hamstrings activity result from the postural effort to maintain the pelvis in the neutral position. With the pelvis collapsing anteriorly, the shins are lifted. Imbalance between specific muscle groups is frequent. Hyperactivity of the paraspinal extensors and hypoactivity of the abdominal muscles in the area of trigonum lumbalis and above the inguinal region is common. In the shoulder girdle region, you will often observe hyperactivity of the upper trapezius and upper parts of the pectoralis major muscles, which is associated with elevation of the shoulder blades and internal rotation of the shoulder joints. Arm elevation test. To perform this test, the patient lies supine with the arms along the trunk. Instruct the patient to slowly raise their arms. During the elevation, the movement occurs in the shoulder joints, while the chest remains in a neutral position, and the lower ribs are fixed by a balanced activity of the abdominal wall. The movement should be smooth with centration of the shoulder joints and the other segments of the upper extremities, cervical spine and trunk. Trunk stability is critical for functional shoulder joint centration and optimal function of the muscles that produce the phasic arm movements. Elevation of the arms up to 180 degrees is a kinesiologically complex movement associated with abduction and external rotation in the shoulder joint. Up to 120 degrees, the movement is performed in the glenohumeral joint. From 120 to 180 degrees, the rotation of the lower scapular angle, clavicular rotation, and the extension of the thoracic spine contributes to the movement. All these components must work in synchrony for the arm to reach a full range of motion. Impaired trunk stability affects all arm movements. With insufficient stabilization, the cranial shift of the chest occurs in the early phase of arm elevation. Pronounced lumbar lordosis and protraction and elevation of the shoulder girdles is often associated with thoracic hypokyphosis. Postural stabilization is necessary to create a proximal fixation, punctum fixum, of the scapula for muscles working in the open kinematic chain, pulling towards the scapula and the trunk. Without coordinated core muscle activity, the scapula loses its stability capacity during movement. Often, this results in elevation with early external rotation of the lower angle. The elevation is not fluent and it's associated with internal rotation of the shoulder joints. This can be seen as a decreased distance between the head and the arm. The smaller the distance, the more elevation and decentration in the shoulder joint. The test can be performed with the patient standing. With insufficient stabilization, you often see increased lumbar lordosis. The squat test. The optimal squat pattern from developmental perspective can be observed in a healthy infant at 12 months of age, when the infant uses the squat as a play position or as a transitional position between the bear and standing. During your examination, the patient performs a squat slowly up to the 90-degree angle with the knee maintaining this position. The arms are flexed to 90 degrees at the shoulders and kept in front of the body to balance the posture. The feet should be positioned to the width of the pelvis. We observe the squat stereotype from side, from the back and from the front. Looking from the side, we analyze the axis of the trunk and the lower legs, which should move in parallel. This is only possible with ideal muscle coordination and controlled triple flexion in the leg joints. The ideal movements start with hip flexion. The knees are stable above the forefoot and the torso is held in a neutral position with no visible spinal decentration in the sagittal plane into the lordosis or kyphosis. When watching from behind, observe the trunk stabilization mechanisms. The ideal model of trunk stabilization is defined by proportional activity of the abdominal wall, co-activation of the deep neck flexors and extensors. The spine is maintained in the upright posture and the head is in neutral. You can also palpate the lateral dorsal part of the abdominal wall to analyze the intra-abdominal pressure regulation. In suboptimal stereotype, you will see in the lateral view two common escape motor patterns. The trunk and lower leg axis loses their parallel position and the timing of triple flexion in the leg joints is compromised. An example of poor postural stability is when the knees drive the squat movement, placing the knees in front of the toes. The weight is on the forefoot and the trunk is held too vertically due to lack of flexion capacity in the hip joints. Another suboptimal pattern is defined by the knees moving behind the toe axis. The weight is on the heels, the toes are lifting off the mat, and the torso is bending too far forward to prevent the body falling backwards. In both cases, you will see from the back disturbance of trunk stabilization manifested by exaggerated spinal lordosis or kyphosis with a forward head position. At the same time, muscle coordination is impaired. The spinal extensors are overactive, and with palpation, you will identify insufficient activation of the lateral dorsal sections of the abdominal wall. Quite frequently, there's asymmetry in the pelvic movement and a shift to the right or to the left. This escape may be caused by a weak support function of the entire leg, by structural changes or soft tissue tensions in the area of the hip joint. Viewing from the front, you can frequently identify decentration of the leg joints. For example, the internal rotation of the femurs, with the knees collapsing medially, combined with foot pronation. Equally frequent is the overloading of the lateral side of the foot. However, if the quality of the 3-point foot support is lost, then the capacity for weight transfer is impaired and stability is reduced.